So welcome everyone to this MLE Friends talk. This is actually the final MLE Friends talk in the series for this season. And so we're really honored today to have Dr. Thorsten Barnhofer, who's a member of our association at Mind and Life Europe. And he'll be offering a talk on really the core of his research, which is mindfulness-based interventions in prevention and treatment of depression. We are already there and we are only just beginning. So Dr. Thorsten Barnhofer is a professor of clinical psychology at the University of Surrey in the United Kingdom, where he conducts research into the use of mindfulness-based interventions for the prevention and treatment of depression and associated mental disorders across the lifespan. He has a particular interest in the mechanisms by which mindfulness meditation may reverse the psychological and biological factors that hold chronic and recurrent forms of depression in place. A cognitive behavioral therapist and mindfulness teacher, he regularly offers workshops on mindfulness and retreats for mental health professionals. So with that, Thorsten, thank you so much for joining us and offering your time. So I'll hand over the floor to you. And as a reminder, we will have time for questions. So you can let us know when you'd like to take questions, either throughout the presentation or at the end, and then we'll move from there. So thank you so much.
Hey, thank you, Johanna, for the kind introduction. And it's a real honor and privilege to be with you online, to be with MLE Friends, and to have an opportunity to talk about this particular area of research. So what I would like to do is to take a bird's eye view on the development of mindfulness-based interventions for depression, and to really give you a sense of where we have come from and where we are in this at this point. And I think it's fair to say that this has been one of the major success stories in clinical psychology and psychological contributions to mental health over the past decades. And when you look at it, it's easy to think that actually we've come to a point where the chapter's almost closed. So I'd like to give you a sense of where we are, what has happened over time, how established this intervention already is. But at the same time, I think there are a lot of open questions still, and some of these are quite fascinating to look at, and they open doors to further exploration, which should be really fascinating for the field. So I'd like to give you a sense of both of these aspects. This is why I said somehow cryptically, we're already there, and we're only just beginning. So I'd like to give you a sense of that. Let me share my screen so that you can see the slides which I've prepared, which might take a little moment here. Here we are. So in order to start this journey, I think it's probably helpful to remind ourselves a little bit of the problem that we're talking about, which is depression as a disorder. And this is not a small phenomenon. When you look at the numbers, you will see that generally, mental and substance abuse disorders are very widespread, the leading cause of non-fatal burden of disease. And within that, depressive disorders account for a considerable percentage of this burden. They are actually the leading cause of disability worldwide, and the picture becomes even more concerning when you look at the characteristics of this order. In terms of the course of it, we know that incidence rises abruptly in childhood. So in many people, this is something that begins early in life. Not in all people, it continues to be high in incidence in middle life, in old age. So it's something that stays with us as humans over the entire lifespan. And it's actually something that for many people is quite persistent. So we have two aspects here which are important. One is that there is a high prevalence of depression. The latest data that we have in the UK, for example, a big survey that looked at numbers in 2014. This is a few years ago, and numbers have gone up since then. But it can give us a sense of how big a problem that is. This adult psychiatric morbidity survey suggested that 17%, so 1 in 6 adults within this given period, within 1 year, was suffering from a common mental disorder. And by common mental disorder, they refer to depression and anxiety. They often come together. When you look more specifically at studies in Western countries that look only at depression, then the current estimates are about 6 to 9% of people within a given year. That's a huge number. Really suggests that this is something that is endemic. What's even more concerning is that, as I said, for many people, this is a very persistent condition. So we know now that about 50% of first episode patients recover with no future episodes. But then you have about 30%, 35% of people who go on to experience recurrent episodes, and a further 15% who experience an unremitting and chronic course over many years. When you look more closely at these recurrent courses, you can see a certain dynamic there, which is that risk of relapse to depression increases with number of previous episodes. So there's a risk of about 50%, as we've said, for relapse after a first episode of depression. Now, if someone has suffered from this first episode of depression and we look at the further trajectory, risk increases over time, 70% after a second episode of depression, that it will come back. And about 80 to 90% even, so very high estimates of depression coming back after a third episode of depression. So people are almost certain to have a further episode of depression if they've suffered from 3 previous episodes. Within that, episode acceleration is a common phenomenon. So the interval between these episodes in many people becomes smaller. And when you put all of this information together, you get a picture of a disorder which is pretty much progressive. So there's something happening over time, something is being learned, something is happening in our minds, and certainly, and that's what we've learned over the years in research, certainly also something happens in our brains and bodies over time. So there are underlying vulnerabilities which we have learned about more in research that make this a condition that is quite difficult to treat and that comes with a high risk for relapse. And this is something that wasn't always appreciated when it came to developing therapeutic approaches for it. As you can imagine, of course, the main concern is to treat acute disorders, to help those people who are acutely suffering. But one of the aspects that really was new about mindfulness-based cognitive therapy was that this came in with the express aim of addressing these causes which become more and more recurrent over time. So there was a sense of taking into account the progressiveness of this disorder and thinking about the kinds of things that need to be addressed in order to make sure that whatever is this underlying vulnerability that keeps driving it is in some ways ameliorated and can play itself out in the way that it usually would do. There's another aspect which I would like to highlight before going into the development of the treatment, which is that we now know that depression isn't something that is just isolated as a mental health event, but that it actually is associated with an excessive risk for chronic physical disorders. So especially people with these recurrent and chronic courses have a significantly increased risk to develop chronic physical disorders such as arthritis, asthma, diabetes, and others which are listed here. And we also know that depression is a significant risk factor for the development of more degenerative disorders in later life. So disorders such as Alzheimer's disease, risk for those is determined to quite a considerable degree by previous histories of mental health. That's something which we've learned also in the past decades, I think. So the development of mindfulness-based cognitive therapy, which is the intervention that really is at the core of all of these developments, which I'll be talking about, was a response to this understanding that here's something that is recurrent, that is persistent, that when we treat it, even with good existing treatments, shows a high likelihood of relapse. And what these three friendly people who you see here underneath the manual, Segal, John Teasdale, and Mark Williams, did was they brought together two different traditions and strands to produce this approach. One strand, which is signified by this friendly person with bow tie. Here is cognitive therapy of depression, which dates back its development to the 1960s, 70s, 80s, and then a much older tradition, of course, which here John Kabat-Zinn stands for, who can be credited, I think, with translating the Dharma for a treatment program that is now very widespread and successful in our healthcare systems, mindfulness-based stress reduction. And Mark, John, and Sindel learned about the ways in which these two strands can be quite helpful in combination. The development, however, was not so much one that was driven by a thought that perhaps they like mindfulness or they're passionate about meditation and that's why they want to use it, but it was really a scientific development, one that started out from this problem and that looked at what is the best way of understanding this? What's the best way of framing these dynamics, and what can we learn from that in order to then find the best possible ways of addressing this. And that, of course, starts by asking yourself, what is it actually that is driving this trajectory where risk of relapse gets higher episode after episode after episode? And the first thing that they looked at, and the researchers at the time looked at, the whole field looked at, was whether this is something that has to do with stress in your life. So we know from depression research dating back over decades that stressful life events precede the onset of depressive episodes, a pattern where we sometimes see people being faced with difficult events in their lives. They try to cope with it. They exert energy, and at some point it's just too much, and that's where depression kicks in. And this is certainly something which is visible, so there is a strong relation. But interestingly, and this is what's depicted in this slide, that's taken from the manual of MBCT. When you look at the different studies, you see a very common picture emerging, which is that the relation with stressful life events is strong for first episodes of depression, but then when you look at second episodes of depression, third episodes of depression, fourth episodes of depression, that gradually diminishes, suggesting that perhaps stressful life events for later episodes are not quite as important as they are for the first one. And perhaps what happens here is much more autonomous. It can be triggered by smaller events and then runs its course. And so the question then from this perspective is, how do you explain that? Are there any good theories to understand this? And for Mark, John, and Zindel, one obvious way of framing this was to use a cognitive model. A cognitive model that assumes that this has to do a lot with learning, with what people learn in terms of how they make sense of the world, how they approach the world. And this is where the link to cognitive therapy is very important. Now, cognitive therapy assumed that at the core of risk for depression is previous learning, where previous life events, particularly those that you're faced with in early life, can bring you to develop certain beliefs that tend to make you look more negatively on what is happening in your life. And this then becomes part of your belief system. Cognitive scientists will refer to that as a schemata, and this type of therapy would work together with people, with patients, by trying to find their particular beliefs and by trying to help them to see whether they are actually helpful or not. And if they are not helpful, then to replace them with more realistic evaluations. So beliefs, schemata are an important point, and this certainly is something that also the theory underlying MBCT would acknowledge. But there's another aspect to it, and this aspect is more process-oriented. And it has to do with the question of, if this thinking, if these beliefs are so important, what is the dynamic of them? Are they always present? Are they always at the forefront of our minds? Which research suggests that at the time, actually they might not be. And then there's a question of what's happening there. And there was a part of this research trajectory where people were really interested in these dynamics, and progress arose from experiments that looked at a phenomenon that we now refer to as cognitive reactivity or differential activation. And let me describe you one of these experiments, or perhaps the general paradigm of these, which is to look at thinking in people who are not currently depressed, but who have a history of depression and therefore should show these particular vulnerabilities that we're interested in. And the studies would compare them to people who are fine at the moment, just as the other group, but who've never had depression in the past, so who didn't come with this kind of history. And you can take all kinds of tests that look at vulnerability. So something that taps into negative thinking, into these negative beliefs, into memory biases. All of these are part of depressive thinking. And you test people just as a baseline test, the people in these two groups with some test of cognition. So this might be a questionnaire of negative beliefs. And then the second step within that is that people received a mood induction, nothing too dramatic. Usually what's being used is negative music, and perhaps you can all sympathize with that, the experience of listening to negative music, and it can change your mood a little bit, but nothing dramatic happens in your life. But certainly there's some change in mood, and what we've seen in these experiments is that yes, people's mood changes, and it changes in very subtle ways, but there's no difference between those people who have a history of depression and they're fine now, and those people who have not had this history, so both change in their mood. Here's the crucial step then in these experiments, which is then to test them again using this questionnaire, for example, of dysfunctional beliefs, after they've had the mood induction. And this is where the difference comes in, that was quite a crucial learning for the development of this intervention. At this point, you actually see a significant difference between the people with a history of depression and those people who do not have that history. This kind of thinking, which is typical of depression, can be rolled in and activated just by very subtle changes in mood. And when you run these experiments, and we've done a lot of these back during my time in Oxford, I was the experimenter for a lot of these. And when you debrief people afterwards and tell them about what's happened in the experiment and why you do it, or what can be learned from it, then usually we would also ask them, did you notice anything happening there? Did you notice what we saw happen? And most of the time people would say no. So what was very visible for us, what's visible in our data, wasn't visible and noticeable to people themselves. And that tells you a little bit about what's going on here. So there's a certain kind of thinking that comes in, that is being brought in just through subtle activations. People are not aware of it, and it can unfold its own dynamic. And the suggestion here was that this is due to the fact that in previous episodes of depression, learning has taken place. People have learned by going over this kind of thinking again and again and again during these episodes to think in these ways, and that's why it's more accessible. It can be triggered very easily. And then what happens, what we've learned is that these activated tendencies are then kept in place by maladaptive responses. So there's a tendency for people who suffer from depression to want to think their way out of it, to use the same kind of problem solving that in so many other situations in life is something enormously helpful, yet in this situation, often we know it backfires, and it moves into a kind of ruminative thinking, going over problems again and again and again. Oftentimes that oscillates with avoidant tendencies or the tendency to suppress. And again, those can have paradox effects and backfire, and people get stuck within them. So you see how the cognitive research at the time brought us insights not simply into the content of thinking, which was the focus of cognitive therapy, but made progress possible by giving us more of a sense into the dynamics of thinking. And then the conclusion from that for the development of mindfulness-based cognitive therapy, what Mark, John, and Zindel drew from this was relatively straightforward, because this clearly suggests that if these patterns of thinking, which can become more autonomous over time, which are so pervasive, and oftentimes start without people being really aware of them, if these are so important, then clearly there's a need to help people to recognize these patterns, to become better at recognizing them, and to train themselves to disengage from these patterns. And this is exactly what they said the core skill of mindfulness-based cognitive therapy is. And when you ask yourself the question of how do you best train this core skill, then certainly what you see is how this core skill is something that very much overlaps with what we train people when we train people in mindfulness, because mindfulness training really is a training of metacognitive awareness par excellence. And so the idea here then was to have a training over 8 weeks that in a very structured and stepwise fashion helps people to build the skills to be better able to recognize those patterns. So the first half of the program is very much about building general skills like stabilizing attention, concentration, steadying the mind, learning to notice, acknowledge. Also, of course, a very important aspect of it to increase bodily awareness. And then there's a second half of this program in sessions 5 and 8, where people use these capacities then to work with wider awareness and to use all of what they've learned as a basis for investigating painful thoughts and emotions with interest and kindness. And you see in those descriptions what the main characteristics of this at the time very progressive. It's easy to forget how progressive this development was at the time, what the main characteristics are. This is something that is training-based, and this is something that utilizes mindfulness. This is something that is acceptance-based, and this is something that very much comes from an embodied cognition perspective. So how good is it? Usually to introduce a new treatment and to have evidence of its efficacy that would allow to bring it into our health systems is a journey of many decades. When you look at how long CBT, cognitive behavioral therapy, took for this, it's almost 4 to 5 decades for it to be fully established. And so this takes time, yet for MBCT, it happens quite quickly. The manual of the treatment was published in 2000, I think, or 2002. I'm not quite sure actually at this point. And it was published already with the first large clinical trial results as one chapter of this manual, which I think has been very helpful to establish its evidence base. And so you can see from the very beginning, this is something that was steeped within evidence-based science. It has been driven by data and not just by good ideas, however good these ideas are. It's been driven from the very beginning by data. And so the first trial that was published with the manual compared mindfulness-based cognitive therapy to a relatively wide comparison condition, which was to say, we're going to look at this compared to the treatment that people usually receive, which at the time was most people, if they received a treatment, getting antidepressant medication. And antidepressant medication during that time perhaps was not quite as rigorous as you would hope it to be in these days. And so what emerged out of this initial trial was that in people who came with a history of 3 or more previous episodes of depression, MBCT halved the rates of relapse over 1 year follow-up compared to this treatment as usual condition. The effects were not quite as good in people with 1 or 2 previous episodes of depression. In fact, that was not significant. And so that's been something that has dominated further research for a while, but I'll come back to that specific finding. It is in line with that suggestion that this program is particularly for forms of depression that have become more autonomous, more recurrent in shape, but the data are more varied at this point. The second study, the second larger study, was also conducted by the authors of this manual, and it replicated the results of the first study almost identically. And so with 2 big trials and some smaller trials that also had come out at the time, this was something that, because of this evidence, already found its way into treatment guidelines, which is very important to establish within the health system. But of course, the history has continued, and researchers have then continued to look at other comparison conditions, and the gold standard in the field is maintenance antidepressant treatment. So usually the recommendation by guidelines would be that people receive antidepressant medication for at least 2 years. And the question was, is MBCT an alternative to this treatment? Can it be just as effective? And the data have been quite encouraging. And what you see here, the slides in front of you, is a meta-analysis. In 2016, this was published, and it brought together all of the individual data from previous trials to get a better sense of what is going on here. And the results clearly suggest that MBCT is superior to treatment as usual, and also taking all of the trials at the time that compared against maintenance antidepressant medication, taking all of these together and comparing, there seemed to be a significant advantage for MBCT. This advantage was not of a big effect size. So the best way of interpreting that really is not to say, oh, this should be preferred to some other treatment, but it clearly suggests that this is just as good as the gold standard. And if there are people who would want not to take antidepressant medication over prolonged periods of time, then this certainly is a viable alternative for them. There's another aspect here, which is interesting, and I'll come back to that one a little bit later, which is when you compare MBCT to other active psychological interventions, there isn't actually much of a difference between them. And that's perhaps not too surprising, because it's very difficult to find differences between active psychological interventions. You need large studies with a lot of power to find those. And we know that there are a lot of common elements to psychological interventions. This is why it is difficult. But yet, I think there's an important question in that, which I would like to come back to. But just to give you more of a sense of this research trajectory, there are treatment guidelines which you find in many countries. The treatment guidelines in the UK are called NICE guidelines. The National Institute of Clinical Excellence, and this institute has just recently commissioned another review of treatments for depression that's come out in 2021, and very clearly it recognizes mindfulness-based cognitive therapy as one of the important ways of helping people who have a history of relapsing depression. Also, what you will find within this is a recommendation for people with mild to moderate symptoms of depression. And again, this is something which I would like to come back to. So mindfulness-based cognitive therapy is recommended through these guidelines, and that means it moves into the care that health systems offer on a daily basis and across countries. And we have some data emerging from this which show that the effectiveness of this in real world healthcare settings is actually quite encouraging. These data are not of the same quality at this point in time as the data that we're getting from controlled trials, but they give us a sense of what is going on. Now, here's an interesting aspect though. When you look at the real world healthcare applications, one of the concerns that we have is that with depression, the question seems almost not so much what should we give to people, but we're still not very good in bringing treatment to people at all. So about 50% of cases of depression in Europe go undiagnosed, and those people do not get any treatment at all. And so within that, then it's sometimes quite difficult for treatments to find their particular place. And you can imagine that a system that has a lot of demand to deal with doesn't easily make space for something that is actually about relapse prevention, because the first thing that is on people's minds, of course, is to help those who are within acute episodes. And so there is a movement within the health systems to open the treatment more and more to those people who come with symptoms. And we see from these data here, I've listed two examples of studies that have had relatively large samples, that even if you do that, even if you open this to people with mild to moderate symptoms, the effects seem to be quite good. And that's something which is a development that perhaps the authors didn't foresee at the beginning of this, because they were quite adamant that all of this mindfulness training is something that could easily be overwhelming for people who are in acute episodes of depression. So the suggestion was to really have this as a relapse prevention program, but not for people who are suffering from acute depression. Yet, what we see from the meta-analysis, the 2016 combination of all existing studies at that point in time, is that actually the higher people's symptoms are, and this is residual symptoms we're talking about. So people often do not recover fully, but they continue to have a certain level of symptoms. And the higher that level of symptoms seems to be, the better the effects we're getting. So something quite interesting here. And of course, when you think about mindfulness, or when you think about that one strand of the development, mindfulness-based stress reduction, then the model here is that we provide something to people which helps them deal more adaptively with difficulty. So what John Kabat-Zinn did was to bring this to people who are really in the midst of suffering from physical disorders, and often emotional disorders alongside that. His groups were quite mixed. And the same principle applies to MBCT. We are identifying those processes that make people get stuck in depression, and we help them to respond differently. And if you take that seriously, then actually the model you're working with is a stress buffering model. And that implies that the higher the level of difficulty, the higher the level of stress, the higher your effects should actually be. So interestingly, we have then a development in the literature where we have moved towards the exploring the other end of the spectrum, where we say, you know, should this be restricted to relapse prevention, or does it actually have something to offer to people who are in the midst of these difficulties? And we have a number of studies now out there that speak to this. MBCT for chronic and treatment-resistant forms of depression, and they're all looking quite positive. They're not quite as big as the trials we have. The evidence is not quite as convincing at this point, so this is a question that research addresses, but it looks quite promising. And there are open questions, of course, and one of them is, you know, is there an upper threshold of symptoms at which the treatment is not feasible anymore? So is there a point where people are simply too depressed to really benefit from that? When we look at the data we're getting, then we actually realize that there seems to be a linear relationship. So from the data, we're not getting any sense of this. And there's also a question then, where is it best situated? Can we actually move towards those steps within the healthcare system where people come with current symptoms? And so when you think about these questions, you will have to ask yourself, what is this actually particularly good at? So what are these mindfulness-based interventions uniquely suited for? What is different with regard to other treatments? And I mentioned that we have a number of studies that speak to that. Studies we've conducted, which I was part of, Williams et al. Published in 2014, which compared MBCT to what we called a dismantling control, a control condition where people would receive all of the ingredients of mindfulness-based cognitive therapy, but they were asked not to practice the meditation. So mindfulness-based cognitive therapy without the meditation practice. Another one published by Shellcross et al. In 2015, comparing against a completely atheoretical control that helped people with certain aspects of their well-being, but wasn't particularly geared towards depression. And then a study by Meadows et al. That had a very minimal control condition, which was simply a monitoring of symptoms, which also can be quite helpful for people over time, but you see how this is a minimal intervention, particularly compared to the huge amount of practice that we usually ask people to get engaged in mindfulness-based cognitive therapy. And as I've said before, the results from these studies do not show a significant advantage of mindfulness-based cognitive therapy over these other active psychological controls. And of course, one of the explanations for this could be that there are many common factors to these. So it's simply about aspects like alliance, empathy, expectations that are being built by giving people a good understanding and models of what is going on, and that these are important across however small your intervention is, and that this is driving the effects of what we're doing, and that it might just be in these cases, in these studies, be more relevant than the specific factors. Yet, I think that really is a very crucial question, because when you think of mindfulness-based cognitive therapy and our other mindfulness-based interventions, we're really quite adamant that there is something about the meditation practice, that we want people to engage in this, to learn from this. And we have a theoretical understanding that there is a unique contribution from this. I see a raised hand. Let me stop at this point. Yes. Hello?
Annie, would you like to ask a question at this point in the midst of Thorsten's presentation, or you would like to do it later? We can't hear you yet.
We can't hear you, unfortunately. You have to unmute yourself.
Yes, I might say other things later, but to me, the concept of a disease called depression is the first mistake. All we have is symptoms, but depressive symptoms come together with a lot of things and have the same root causes as a lot of chronic diseases. Myself, I've been studying training there's a whole movement around embodiment, work with the regulation of the nervous system, work on traumas. And in this field, there's some work done with looking at all these factors. And sometimes you can work through biology, sometimes you work through psychology. So this is a totally different way of looking at things. And also research is quite legitimate. I learned a lot of things there. But when you talk about alleviating people's suffering, you need a toolkit. All the good therapists I know use a variety of tools. And we know that the therapist is the first drug, the first, this is measured. And you cannot study that by scientific methods. And I think this is really very important. So yes. That's it. That's it for now.
Yes, thank you for raising that, and I hope I've spoke a little bit to that by conveying a sense that this condition, which, you know, for the sake of science, for the sake of approaching it from a scientific perspective and seeing its regularities, is something that has a lot of complexity and is associated with all of these different aspects which you mentioned. So yes, thank you for that. And so we do work with a lot of complexity. And in order to be able to do that, I think from the scientific perspective, the beauty is that we frame it in particular ways to find our way into it. But much more can be done. I completely agree with you. Yes, I see.
Also, there's a confusion between Kabat-Zinian, mindfulness-based cognition therapy, and, for instance, the other techniques. For instance, ACT. It's more complex. It's fairly easy to learn. Kabat-Zinian, MBCT. But ACT is a lot more difficult. And it's really important not to identify behavioral cognitive therapy with Kabat-Zinian approach.
Yes, I completely agree with you. That is really important to understand that when we're offering a kind of treatment, that we really do it from a clear understanding what we want to achieve. And there are many different ways, some overlapping to a degree. So ACT and mindfulness-based interventions, for example, with good reason, are being described as part of a third wave of cognitive behavioral therapies. So yes, let 1,000 flowers blossom. Many of those help.
But when we are into Kabat-Zinian approach, sometimes it looks like you have a solution in search of a problem, which means you have a hammer so you can handle nails, and there's a danger with that, because you have one tool, and then you need more tools, even within mindfulness-based approaches, even that, but we need also other approach. And this danger, I see that in meditation, that people want to learn meditation, they send into MBSR, as if that was, the approach. There's danger in that.
Yes, certainly there's danger in oversimplifying approaches, and I think that's why science is so important. I was just about to unpack a little bit what is in this approach, which in many ways is quite complex and has its beauty there. But as you said, when we oversimplify, then we are in danger of making mistakes. I'll just take, if that's all right with you, I'll go a little bit more into those mechanisms, and we'll have an opportunity to come back in more depth to these questions. I'll take one more question. I've seen another hand up before we continue.
Bruce, do you think you would want to share your question now in the current phase of the presentation or after the presentation?
Thank you. Just before I don't want to interrupt your presentation, I'm sorry. And I realize that it's on a very specific aspect of psychological treatment for recurrent depression. But Annie's point there is valid. Once we start to discuss depression as a whole topic, we need to start with the definition of depression, which inevitably comes out of the survival response and involves a social context. So it becomes both embodied and inactive within the social context. Depression is not an internal practice. And in the same way that mindfulness is not an internal practice, simply acting through the brain. So I do respect Annie's discussion there, but I think that's a wider discussion on the nature of depression as an inactive social phenomenon in which the individual and society plays a part. I was trying to respect your presentation, and I believe you're about to go on to part of what I was going to say, which is, the proposed mechanism that you've been talking about for the third wave cognitive therapies basically helps individuals make a transformation at the root of their relationship with those thoughts, feelings, and physical sensation that contribute to activating and maintaining psychopathological states. That's what I understand you said so far. And that while CBT traditionally dealt with thoughts by aiming to dispute, change, and restructure their content, The third wave therapies, including MBCT, take the different approach of focusing on the process of thought, the relationship between their person and their thoughts and feelings. Essentially a mechanism of change that facilitates, and I think this is the important thing, individual additional psychological mechanisms such as self-regulation, cognitive, behavioral and emotional flexibility. And my suggestion, because you just put up a slide as to what are the components, I think we need to look at components within the third wave, and if we look at mindfulness, contemporary mindfulness, and relate it to Buddhist mindfulness, we find that there are three things within the Dharma that Kabat-Zinn used: of intention, attention, and an attitude of acceptance. And of course, this, as you said, does not require Buddhist meditation. ACT was one of the third wave therapies that used this psychological distancing, but did not require even mindfulness as a practice to be taught. And I think the focus on these components of intention, attention, and the attitude of acceptance, the beneficial compassion, loving kindness, which as part of the Dharma was brought into the third wave therapies, are the critical components, and that these were put together as intentionally paying attention with a non-judgmental attitude. These are what lead to this change that you've been talking about in the individual's relationship to perceived experience. This form of psychological distancing. And so and you're probably about to discuss this, but in going forward with the research, we need to look at the changes, the changes that we're seeking as therapeutic outcomes, self-regulation, cognitive, behavioral, and emotional flexibility, as actually deriving from a complex system as emergent properties. And if we focused on intention, attention, and an attitude of acceptance, without necessarily tying them into any particular what would we say, spiritual framework, wisdom tradition framework, we may finish up with an understanding of the underlying components, which we can then apply, as in your very first graph, to the pre-adolescent children who are on an upward curve. And if we can change their relationship with perceived experience before the adolescent growth spurt, we actually have the potential to reduce the entire level of adolescent, teenage, and adult mental health problems in this area.
Yeah, thank you. Yes, so I think it's what I take from your contribution is something that does relate probably very nicely to that second aspect, which I talked about. You're well aware that our whole field is moving towards looking more closely at mechanisms, as you have suggested, and identifying those mechanisms, which are the ones that are most helpful for us. So when we talk about complexity within that, then I think that's something that everyone acknowledges within the field, and yet at the same time, the beauty of our interventions is that they can focus on those aspects which are core components and active ingredients for change. And it's important for us to identify those because we can't change everything. We often think of this almost like a carousel model. So you will see that for depression, for example, if you move the cognition, then the biology changes as well. If you move the biology, you can see the resonances in the cognition. But a real question for us is certainly to say, okay, as we bring all of this together, maybe even within the wider field, we should really get interested in what are the core mechanisms, what does give us the best handle to provide pragmatic and helpful treatments. So let me give you a little bit of a sense of what research within MBCT has to offer towards that. And this is something that is, and I agree with you, much more needs to be done, because this is something that often comes as a second thought. The usual development is that you have theoretically guided interventions, then they're tested for their efficacy, and the next step then is for people to look more closely into, does this work in the way that we would expect it to work? And sometimes our theoretical reasoning is much more developed than the data that we have. And necessarily you also find that in this field. I've listed a few of the mechanisms of action that have been demonstrated to be relevant within MBCT research, and reassuringly, you get a sense that changes in global mindfulness is something that supports these changes. But really what was theoretically at the heart of what this treatment wanted to achieve was the ability to decenter. And I think both of you have described that already, a capacity to shift experiential experience, our relationship with what we are experiencing. That's at the heart of what MBCT wants to teach people in the midst of difficulties. And we have formal research that suggests that indeed, this is what mediates the effects. It's very difficult sometimes to do this research because you have to demonstrate not only that there's a change in symptoms, but that a change in this particular capacity then is responsible for your change in symptoms. And that's what we know from some of the studies. And from some of the studies and the early studies that decentering does that. However, when you look at it, and you might be pleased to see that given your arguments concerning ACT, there are studies that compare across different forms of treatment. We know that decentering is something that many treatments suggest is a central component of what is helpful for people suffering from emotional disorder, and particularly depression. And that's what we find in CBT and MBCT. So we don't have findings that would say, okay, with all of that MBCT practice, people are necessarily better, but it's a different route into that. And we need to have people continue with their practice in order to get these effects. And again, I think that's quite interesting. Then another aspect, when you think about that comparison that you've brought up with ACT, for example, but also with other interventions like CBT, for example, if you ask yourself, is it necessary to have all of the quite rigorous mindfulness training incorporated in this, then again, we can check this and we can look at, is there a change in cognitive functioning in these basic capacities which we're assuming are supporting people's utilization of these active ingredients. And actually what we see with 8-week mindfulness-based interventions is that despite the training, the changes in basic cognitive capacities are relatively small. And when we compare to active interventions, they're actually non-existent. We don't find significant differences here. So I think there's something which probably resonates with what you just said, where as scientists working within this strand, we have to ask ourselves, why is it so difficult for studies to identify unique contributions in mindfulness training? And certainly there are, because this is a treatment that brings its unique characteristics. And one of the reasons I would suggest why it is quite difficult to see that is that we're not usually in trials and in real world applications of these interventions. We don't see practice to the highest levels. And there is evidence, here's an example from one of our own trials, that clearly suggests the more people practice, the more they benefit. So in this case, there was a 50% difference in a risk of relapse over a year following the trial between those people who practiced above the average during the 8-week intervention and those people who practiced below the average. That's quite impressive. And so one of the things that will be important for us as a field going forward is to say, okay, if we're really interested in this active ingredient, then we want to see more studies that actually bring up the practice to a level where it's really influential and we can see more clearly what is happening here. And I won't go into the details, but I can I wanted to show you another example from a study that we've conducted where we followed this strategy, where we asked people who are quite severely depressed with long histories of depression to practice regularly twice a day and to do this over a shorter period of time of just 2 weeks. And we made sure that people adhered. So 90% of people practiced on average 90% of what we asked them to do. And if you do this, then you can see even in brain scanning studies that you have very precise relations between changes in the brain and their reductions in symptoms, their use of decentering, and the reductions in ruminations, which are core parameters from our perspective of addressing depression. So I don't want to go into this entire study, but simply as a suggestion, if you bring up the study element, then actually the practice element, then actually we're coming to a point where it is easier for us to do this. And we will have to ask ourselves at this point, where clearly this is a helpful and established treatment, and yet still 50% of people do not respond to it. We still have potential for the wider field to improve. And we ask ourselves, what are the next steps to improve? Clearly, those are about saying, what is the unharnessed potential of this? And this might be in different formats where we want people to practice more intensively and perhaps for longer periods of time. And where the field will have to move into addressing questions about how this translates into other aspects of depression, other than the cognitive aspects, and particularly of interest for us in this context is how do we connect that to the learning that has taken place in the field about all of the biological factors that we know keep depression in place. So we know by now that there's a real cascading from stress, dysregulations of stress that lead to endocrinological changes that then lead into longer term inflammation, low-level forms of inflammation that then influence the brain, that are implicated in depression itself, the occurrence of depression itself, but also in degenerative processes that we then see affecting brain structure. And there's a real question here whether these, with longer times of practice, are reversible, can be buffered step by step by step over time, as we see in people who practice over longer periods of time not being depressed. And we, from this perspective, also have a window to asking wider questions, such as if we can have those kinds of effects, will that help us, for example, to prevent the onset of dementia? This is something that we've tested in the Silver Santé study, the Method Aging project that you might have heard of before in presentations here. And I completely agree with what you've brought up before, that this kind of understanding also needs to be applied to the prevention of depression. So personally, I am lucky to be involved in a larger project that looks at bringing this to younger people, to stop the trajectory of depression at an earlier stage. So thank you. This is where I wanted to stop. To give a little bit of a sense where we are. There is a development up to a point where we really brought something, where this has brought something into the health system, where people are benefiting in real world health care settings, and where at the same time, I think a real window of opportunity exists for further research to have lots of beneficial influence.
Thank you so much, Thorsten, for your talk. And I just want to mention briefly here, before turning to more questions, that you referred to Willem Kuyken in some of the slides, references to his articles and others as well. And he's going to give a talk in the Mind Matters series in the fall about exactly where you ended, how to move on after all these 20, 30 years of experiences and learning, and how to develop the approach further, including lifelong interventions and other areas. So he will also share some additional details of research and probably even some critical elements with regards to MBCT, as you have also indicated, that it is good for this and not good for that, or it works here and doesn't work there, or it's better than this but not necessarily better than that. So he will also add more content to this aspect of the discussion, and also maybe how to develop this further. So it would be great to have you, Thorsten, there in that particular meeting as well, and have an exchange together, maybe based on your talk today and what he would add on top, and then extend the discussion with the community who is here today and who is going to attend that meeting as well.
Thank you. Yes, I'd be pleased to do that. So thank you.
Great. So Ode indicates a question. Maybe you want to raise yourself.
Hello, and thank you so much for this presentation. Yeah, this was wonderful. So just as an introduction, I am not a psychologist. I'm a practitioner, among other things. And so one of the things that I was wondering is, because this is an 8-week course, whether it's MBCT or MBSR, I know ACT much less. So we were talking about decentering, and I'm asking myself if you have some insights about
how does this process of decentering unfold? And I will link this maybe to tell you a bit more what I'm thinking about. So for example, if I focus my attention on a specific object, and I hopefully manage that fairly well, then by being so close to that object and being able to observe it, then I can see a potential dissolution of that, and from that insight, maybe it allows decentering. Another possibility is my attention is stable and I'm just noticing, whatever arises, whether physical, emotional, thoughts, etc. And I'm just asking myself, if you have some insights, on how this process unfolds.
Yes, that's a very good question. And again, this is subject of research. It is, thank you for pointing towards that, quite a complex, it is quite a complex construct that requires a number of different skills and capacities. It requires us to somehow recognize and hold the relevant experience, and then also to have a recognition of this having a certain impact, recognizing that it is possible to shift perspective. What it is within the interventions that we're offering, I think oftentimes what you see is that it is quite a fluent process, and it starts for patients actually not in the same way it might be looked at as you've just described from a meditator's perspective, where you already describe a very clear view of this and a very clear operationalization. I think the starting point for people who come to our courses and who realize they get stuck again and again and again in this mind state is simply to see at some point where this has been going on, you can recognize this for what it is. And you can move away from this. And this is already liberating. So this might not be an online process. This might be a chain of rumination that has been going on for half a minute or maybe for 10 minutes even. And this recognition comes in and there's a recognition, here's a different place to stand. And with practice, we come closer, we bring people to come closer and closer to that point where they actually see arising what might be earlier points in that chain of events leading into this. So that's an important in-between step to actually see how do certain events in the mind come with particular feeling states that then come with a quality of aversion or attachment, and we go down certain routes. And so it's a stepwise training towards that.
I want to resonate here because I'm doing research with voice science and contemplative practices. And when you were saying offline, that's what you said, right? Yeah, it's just interesting the parallel I'm thinking, from a motor perspective, when you were saying offline, and then what I was saying is definitely online, and thinking about, the planning of an action, which is, considered offline and online. I just thought I wanted to resonate because I find it quite fascinating.
Yes, absolutely, and we approximate in our sequence within these approaches. We come closer and closer, I think, to the online, and as you know, there is a sense that in open awareness practices where we just meet this, and there isn't this particular shift. It just doesn't have that capacity to draw you in anymore. Yeah, but those are there's a certain trajectory in practice, and we are very pragmatic in doing this. So we start from a point where very much about recognizing, disengaging, and that can be a process that's relatively far from what you experience as a very experienced meditator.
Thank you very much.
Thank you.
Before moving to the next question, maybe we can ask you, Thorsten, to close your screen sharing so that we can.
Oh,
everyone.
Apologies. Yes.
No problem. No problem. I should have asked that earlier.
I was so focused on the
No,
discussion.
no problem. Yes, indeed. It's really interesting, and probably we can come back to you, Bruce, because you have posted another note in the chat, and this is an interesting one. The connection between Buddhism and these interventions, or the general condition for well-being, whether that's specifically this or that or more general. So you would want to share that note or comment and question maybe.
Right. My comment was made actually at the stage of Thorsten's excellent talk, where we were talking about secular applications not really requiring meditation or even Buddhist practices such as mindfulness. And I was just going back to Gethin, who is a Buddhist scholar, who suggested that the Buddhist Eightfold Path could be understood as descriptive of naturally occurring causality, where certain actions and courses of training help to transform thoughts and actions within the 8 aspects of those leading, in the Buddhist case, to suffering and others to well-being. So in a sense, we have actions, causality, but we then get the emergent properties of symptoms and outcomes as a complex system. So mind training is offered within this Buddhist tradition, which helps one to align one's behavior with this structure of reality and attain liberation from suffering. But of course, causality is not an invention of the Buddha, any more than gravity was the invention of Newton. These 2 luminaries were actually describing something, principles that exist. And therefore, there is no reason in principle why explicitly Buddhist teachings are a necessary condition for well-being. The perspective that the outcome of training transcends Buddhist teachings is relevant actually to understanding the ways in which mindfulness has been adapted for secular applications. And just to make one more point, as we are talking about a complex system with emergent properties, even if those emergent properties are secondary things like self-regulation or outcomes of research, at the end of the day, you cannot reduce a complex system to its component parts. So it's important to look for the most important components and mechanisms, but realizing that we're not going to be able to reduce them, that there is something more going on with the complex system, which is almost certainly the inaction, the embodied inaction within the contextual environment of the individual within society. And that these factors are something that awareness reveals by working on the basic components. And I think that may also take in what Aud was asking, because certainly the practice that she was talking about talks about awareness causing the arising thought feeling to be self-revealing. So we have awareness, which is a metacognition, self-revealing within the process. And of course, again, applying it to Buddhist meditation, it can then be self-liberating. So you have the potential not only to reveal the complex problem, take the layers off it to reduce it down, And again, there is a practice called Hifferwith, how I feel about what I feel, which would resonate with a number of psychological methods to essentially achieve a catharsis in which the problem is liberated.
Any comment to that, Thorsten, or we can also invite Shakya to share the note that was posted earlier in the chat, because this might be related to this comment of Bruce as well.
I'd be inclined, thank you, Bruce, would be inclined to just let that stand as it is, and perhaps just comment that from my side. I share that fascination, actually, if you take a different perspectives, and we do that quite often in research. We have our cognitive science perspective, we have a Buddhist perspective from which we can learn, we have neuroscience perspectives which we can take on these phenomena. It's really reassuring to see how often we see general principles reflected in them. They are quite compatible, which is reassuring.
Thank you. And then Shakya, maybe it's a more particular question related to one point in your talk.
Good evening to all. Thank you for giving me the opportunity to ask my question. So this is more understanding question. I mean, to understand better what you meant. So at one point you said that there were comparison between mindful-based therapy and some therapy which use the same tools but without the meditation part. And that's when I realized that what I understood that you use the word meditation as might be different, because generally speaking, from what I felt, the scientific community used the word meditation in a very loose way, which is fine, because in the Buddhist community it's the same. But there are differences between practice, the English word practice and meditation, in the same way as in Chinese, in Vietnamese, in Tibetan, the word mind training, which can be used as lojong, but is loosely used as synonym with practice, which is which encompasses meditation. And again, in Tibetan, the word meditation is meaning habit, just to get habit of. So I want to understand, and I want to know what would be those tools that were used to evaluate whether or not the meditation component, to evaluate the efficiency of this particular component that you call meditation. And yeah, so please, can you explain that?
Yes, yes, of course. And thank you for this question. Thank you for the opportunity to clarify. This was a clinical trial, and usually what you do in clinical trials, you compare different treatments, or compare your active treatment against an inactive control. And the core question for us here was, we wanted to learn whether the practice component of mindfulness-based cognitive therapy, and what I mean by that is simply the 45 minutes per day that people are being asked to engage in different meditation practices each week. So that's the body scan at first, and then there's different forms of mindful movement and different forms of sitting meditations. Whether this is the crucial aspect in bringing forth the effects of the treatment. And scientifically, what you can do in order to find out is to compare the full treatment, where people come together for the sessions once per week, and then they're being sent home and they practice on their own with guided meditations. Whether this full version of the intervention is significantly better in reducing relapse to depression than a version where people just come together. You don't give them the guided meditations. You don't ask them to practice during the week, but you simply give them a sense of, this is what we think is the important process. And you might want to look out for that and keep it in mind and change your behavior in accordance with that. But there's no change technology. There's no mental training involved. That's what we did.
Thank you, Shaka, for the question. It was a very concrete and particular point that we could elaborate further and learn more about. And thanks, Thorsten, for your explanation and elaboration, as well as the whole talk and the discussion. As I mentioned, this will be continued later in the fall. So this is not the end of the story. It's a very nice start discussing this important subject, depression. As Annie mentioned in the chat just now, actually, given the present reality, climate warfare, politics, economics, etc., it might be healthy to be depressed. But of course, we would need to do everything we can to alleviate suffering and also depression in young people and in society, and also in other generations. So this work is very important. Thanks for the summary, Thorsten, and thank you all for participating. And we will continue this particular subject later this year and probably next year as well, as it is coming to the forefront of discussions more and more. Thank you.
Thank you,
and,
Gabor.
Johanna,
thank you, everyone.
Thank you, Thorsten. It's so good to see you. It was
yes.
limpidly clear. Thank you.
Thank you.
And I would just hand the floor back to Johanna for a little intro of another event we are going to organize in August.
Thank you so much, Thorsten, once again. And we just wanted to give everyone a heads up about the next event that we'll be hosting. We'll be taking a short break at the end of July, and then in August, on August 11th, we're going to be co-hosting a hybrid event with the Teasdale community in Germany, in Nuremberg, Germany. And we'll be hearing from Mingyur Rinpoche, Dr. Antoine Lutz, and Dr. Marika van Vugt. And it'll be a dialogue centering around the natural qualities of mind from both the neuroscientific perspective and also the Buddhist tradition of practice and teachings. So this event will both be live, but it'll also be live streamed. So you are all welcome to listen to it and follow it on the live streaming. We'll be sending out more information as the time approaches, but it'll be on August 11th at 6 p.m. Central European Summer Time. So you can note it on your calendar and you're all welcome to follow the event. So with that, thank you again, Thorsten, and have a wonderful evening, everyone, the rest of your day.
Thank you all.
Thank you. Bye, everyone.